Okay, I do believe we have both Lenel and Jocelyn on the line. Hello, hello.
How you doing?
Good, thank you. Nice to see you again, or speak with
Good
you
to
again.
see you.
Yes, and
so
I got off mute, so we're good.
We may want to put him back on there just to be clear.
We'll take the small victories, Lenel. Well, terrific. So we are going to pivot over now from the app universe where we just were over to really DaVinci and all of the opportunities that the marketplace has, that the industry has, to continue to band together, to learn from each other, and to really just take advantage of the knowledge that's out there. So we're joined today by Lenel James from Blue Cross Blue Shield Association and Jocelyn Keegan. And similar format to how we've done, I'll do a quick introduction of both of these individuals. We had the pleasure of speaking earlier this week, and I'm incredibly excited for what they're going to share. I think it's very welcoming, I think, for the industry to hear. And so Lenel and Jocelyn will take us through some of their slides, and then we'll do some Q&A from there. So Lenel James, who's joined us, Lenel is a business lead for health information exchange and innovation at the Blue Cross and Blue Shield Association. He's the past co-chair of the HL7 EHR work group, past co-chair of the HL7 payer user work group, and co-author of several HL7 standards. Lenel is part of the program management office of both HL7 DaVinci project and the Gravity Project for Social Determinants of Health, and he's a co-founder and member of the coordinating committee of the Office of the National Coordinators FHIR-At-Scale Task Force, so the ONC FAST program. And Jocelyn is our payer practice lead at Point of Care Partners, is the HL7 DaVinci program manager. She's a pragmatic leader who understands how to create, support, and develop the teams that build the software and products and solutions, very much invested in all that is FHIR and all that is advancing these interoperability standards. So thank you both for joining us today. And I will turn it your way for educating everyone who's listening to the conference.
Glad to be here.
Thank you.
Ready to dive in, Lenel?
Oh, of course, always. Let me start with the FHIR-At-Scale Task Force. I was pleased to be working with Jocelyn and several members of DaVinci in working with the Office of the National Coordinator to bring it. And part of the objective of the task force is to look at the challenges of doing FHIR at scale. Several members of both, in looking at this ecosystem, you can see that we've got to the right a lot of the ecosystem that needs to figure out, how do I move this at scale? To the left, a variety of people that have specific areas of interest, whether it's a payer, whether it's a provider, whether it's making sure I know where the medical record is, making sure I know public health. All of those initiatives can be tied through the internet, through FHIR, Fast Healthcare Interoperable Resources, to get the healthcare industry up to speed with the other industries that are taking full advantage of the FHIR ecosystem. But as we get these initiatives to the right, whether it's the Caring Alliance focused on communities, focusing on consumers, Gravity focusing on social determinants of health, HIEs, the trick is, how do we go from the power of this internet standard to how do we make sure it works at scale and it's interoperable? And that's really the focus of FHIR-At-Scale Task Force. What we've got here is a vision of how this collaborative efforts to the left, where a lot of these accelerators focused on what's the functional use case, whether it's value-based care at the top with DaVinci, whether it's Argonaut working on the EMRs and how they work with the rest of the ecosystem and support their providers, Karen focused on consumers, Gravity, social determinants of health, Codex focused on cancer care. Those use cases then get moved. And at the bottom, I don't want to forget that Passio is looking at the post-acute care, and Sequoia, again, making that interoperable exchange nationwide. We've got all that work moving into the middle of how do I use the technology of standards, the things like the identity management, directory services, core networking, care quality, Commonwealth Alliance. And then we've got these common scalable approaches that lead to working in the community or working with the users. But in that effort, it's so important to make sure that we've got the FHIR-At-Scale task force focusing on that, so that each of these different accelerators aren't doing the same thing. We don't need 6 accelerators all working on directory services, when to be interoperable, we need a common directory service. We need common version identification as we move these standards up the chain. How do we make sure everybody's on the same page for interoperability? That's one of the challenges of interoperability, and we're making a lot of progress. And I apologize, we're going to be putting a lot of information into 20 minutes to leave time for a little bit of Q&A.
So I think that to Lenel's point, we're going to rapid fire you guys through this, pass through what's happening in DaVinci, where gravity is, and Lenel's going to be able to sort of bookend us with a little information about sort of how is HL7 as an organization scaling itself to be ready for all of this work that's headed its way. So, you know, Lenel laid out sort of what the scope is and the focus is from a FAST perspective. My team actually supports the FAST initiative in addition to DaVinci. And we've gotten to watch really alongside our work on DaVinci, the progression of how to identify and have conversations about these scaling challenges. And so folks like Lenel and many of the thought leaders from across the industry have gathered not just at the high level, but really around this idea of these tiger teams around specific subject matter areas. I think a lot of the themes, I was able to sit in on about half of the sessions earlier today, and a lot of the themes, and I think of the questions that you're seeing in the chat thread really are around sort of how are we going to move from people being able to do things point to point to really being able to make sure that anyone can be discoverable to anyone else, and that we have the requisite and necessary security and identity management in place. So over the beginning of the project, there really was this sort of discovery session where the industry came together with these tiger teams to identify what the technical barriers were, what the core capabilities we imagined needed to be in place, and how did we learn from the work that was already out there in the industry. And that about a year and a half in, there was sort of this initial version of these are the types of solutions we need. And then over the last year, 18 months or so, the group has really focused that on, you know, what are the things that should be coming out of FAST and out of this community? And I think really evaluating now sort of how do we take that to action? So, you know, all of this solution input was reviewed by our Tiger teams, led by a couple of chief architects that helped found the project with Lenel and others. We had technical learning communities that we created around each of these areas. And then we brought SMEs in to really sort of beat things up in working session style. And we're at the point now where we're really at sort of this next step of, okay, how do we actually start to create the artifacts, the best practices, the recommendations around what standards are needed, what processes does the industry need to support, and what regulation is missing that's going to stop us from being able to get to a place where we have this thriving ecosystem. I'm going to say out loud, I have a couple slides to clear that are more resources for you guys to be able to pull down afterwards. Is this idea is every one of these ideas or concepts that are coming out of the Tiger teams around data exchange, around endpoint discovery, around security and identity has its own work stream. And if you're concerned about, involved with problem solving, or early adopters, come and join the conversation. There's opportunities now to connect at some of the upcoming connect-a-thons, to become part of the actual learning community itself. I use the LinkedIn group to just make sure I'm always aware of sort of the latest thing coming out of FAST or any upcoming presentations and updates. So I really recommend, if folks haven't already done that, to join the LinkedIn group and get involved, because this is, you know, I listened to the last presenters talk about, you know, sort of MVP concepts when we're looking at where we are. We're in the infancy of real adoption and implementation of FHIR around the industry. And those of you that are here on the forefront are going to be able to give the best learnings back into the industry as possible. So with that, I'm going to actually flip and give a little bit more background on DaVinci from a program perspective. So if FAST is dealing with sort of the scaling and the how do we do this, you know, across all of the different ecosystem players, DaVinci really is about, let's pull together a specific group, payers and providers focused on value-based care, and how do we start to create the clinical data exchange that's required in order for people to be successful as we move the industry from fee-for-service to value-based care. Now, I would say 4 years in, which is kind of crazy, Lenel, right? 4 years in, we're looking at use cases that are usable by folks well beyond just value-based care contracts, and are really in this space around payer and provider connectivity. And courtesy of our friends from the feds, we'll unpack a little bit some regulatory, some work we've done to extend our work to also meet some regulatory requirements. But the core work of DaVinci is really building implementation guides specific around a use case, a business problem that needs to be solved, and then supporting that with the community, with the actual implementation guide, with reference software, sample software, and then some testing. I know some folks had asked earlier in the day about what are we doing about testing. For every one of our implementation guides we build, we actually build in test scripts to make sure that people can make sure that, I refer to it as eating our own dog food, that you're actually compliant with what's in the IG. This is just, I refer to it as a NASCAR slide of the participants, just to show, this is a fraction of the people participating in the ecosystem and funding us or supporting us with in-kind resources. But everything that we create and build from a DaVinci perspective, like the other FHIR accelerators, is available for anyone to pick up as open source free implementation guides that are available for anyone to use. And we work really hard to keep our calls as public as possible. And with that, I'll talk a little bit about what the actual use cases are. And I think a hat tip to our previous presenters, we're actually kicking off our patient cost transparency use case publicly tomorrow. And we have been having very lengthy, in-depth discussions about what that patient cost transparency use case is going to look like in API format, given the current state of knowledge and agreement about what's in the law versus what's not yet in reg versus what's going to actually solve the problems for consumers. But at a highest level, I'm going to talk about the use case, and then I'll let Lenel opine a little bit on sort of what this means in the regulatory sphere that we've been in. So if we look at our use cases, they really are focused around sort of work areas. So how do we improve and develop standards so that data can be exchanged around sort of the attestation of quality measures, or to identify that there are gaps in care? There's an area down here to the left, which is around coverage or burden reduction. How do we create transparency and information equity between providers and payers so that people understand what is covered? And I think, again, sort of tagging to our last presenters, we really firmly believe that value-based care is the thing that is going to bring sort of this administrative and claims and pricing information back into the clinical workflow, because it's critically important for patient care for people to really understand what their options are. And their options are very much driven by what their benefits can cover and will cover. And having that rich conversation between a care team member and the patient requires we get better about transparency of information. And then member access and clinical data exchange, really focus on that. How do we get the clinical data flowing so that it can be leveraged by patients, by providers, by the payer that's picking up a patient when they're making a decision to pick a new new coverage, on an annual basis. And then we have some supporting tools. I'm going to pause for a second and let Lenel chime in a little bit about what this has looked like from a regulatory and implementation standpoint over the last year, as we're really seeing mass adoption based on what's been happening with regs. Oh, you're muted. You're still on mute.
Thanks, Jocelyn. On the diagram, it talks about highlighted in burgundy the proposed CMS rules, and then highlighted in tan the final CMS rules. We're going to have to update this because we also have proposed rules under the switch to the new administration that are on pause as the new administrator of CMS catches up with all these pieces. So it's definitely a complicated picture. But in the middle, the patient access CMS rule, which is going live July 1st. And that it was actually, I believe it was a January 1, the rule went into place, but no enforcement till July 1st. So there's a big switch being pulled on July 1st for patient access API, but also in these proposed rules, there was the effort in the envisioning of beyond payer to payer, which is part of the clinical data exchange and final rule. Over on the burden reduction, it's things like cost transparency that fortunately build off of some of the value-based care work that DaVinci did. We can reuse. FHIR allows us to reuse those building blocks of FHIR. So what's nice about this picture of all of these intertwining proposed rules, existing rules, the Consolidated Appropriations Act with $1.4 trillion that also includes expectations of advanced EOB. All of these pieces still fit under the umbrella of the reusable pieces from ONC FHIR-At-Scale and reusable pieces from the FHIR accelerators, because they're built with that same R4 FHIR underlying infrastructure. So what's nice is across all of this landscape, there's reusable pieces. Now, let me be clear, reusable operationally as a payer or a large billion-dollar health system does not mean easy. It just means the staff are going to start with something for which they have 50% or 90% familiarity. So I say that, and I'll wrap up, which is speed to market with FHIR and reusable FHIR-based technology, internet-based technology means that we can move quicker. And I think that's a big message, and I'll highlight a little bit more at the end. Back to you, Jocelyn.
I think that's great. And I've also included resources. The point I want to hone in on, I think, as we look at what Lenel just shared, is this idea of using the API for one purpose then sets you up strategically to be able to reuse that API and that recipe that's in that implementation guide for a secondary, tertiary use that in the past, if we were writing custom code, would really be insurmountable. For folks. So again, resources in here to go to compliments.hl7.org in general is sort of the mainstay of all of the accelerator programs, and you can get links to all of the resources we're talking about today. And then with that, I'm going to let Lenel talk about what's happening over in Gravity.
All right, thank you, Jocelyn. We talked about value-based care. We talked about DaVinci. Gravity is dealing with social determinants of health, started in 2 years ago. The association was part of that group that recognized the value of this tying to health equity strategies. So its focus is to work on data standards at the patient level to make sure we can go across multiple domains. What we've gotten is a variety of participants. I think it's well over 2,000 now, but you can see the variety of stakeholders from the clinical groups, community-based organizations, social service, federal, payers, technology vendors, all getting together every other Tuesday. It's got a public domain meeting. And obviously with some of the health equity challenges of the industry that COVID exposed, there's a real value to this. Even CAQH and NCQA from a quality standpoint have recognized tracking social determinants of health is important, not just for care or for community engagement, but now for quality reporting has come online too. So it's a fast moving target in terms of one of the new accelerators that are making progress in this exciting new space. In terms of how we do it at Gravity, we've got 2 tracks. To the left is terminology. What are the code sets? Because one of the things we've learned in all the accelerators, the codes allow you to have to maximize your automation and tie it to technology. So they're doing gaps in the codes. We're identifying the codes. We're going and actually getting the standards bodies to recognize terminology and code sets for social determinants of health. And on the right, the actual technical side, we're building IGs. We're testing the IGs at Connectathons. We're wrapping up a ballot and expecting it to be published late June, early July, and then working with the communities to be involved in Connectathons and pilots are all happening with those 2 streams. So I think if we go to the next slide, we get to talk about I want to tie all this work back to, again, not only FHIR, but how HL7 as a hub for supporting FHIR. for over 2 years, I'm on the HL7 board. There's been a 2-year effort that's looked at how do you re-envision HL7 to make sure it's more focused, it's more agile, it's more sustainable. And as part of that, 15 recommendations came to the board from 12 task groups. I know it's an eye chart, but let me focus on 4 areas that tie to how we move the industry. So again, if we streamline how the process works, many of you know most of the standards bodies, you will spend 6 months to a year getting to know the terminology and understand their timeline and processes to be more agile and move in today's environment. HL7's got to move faster. The other things is how do you maximize those opportunities for virtual engagement? You used to have to come to HL7 and meet people and get engaged with the work groups using the technologies like that we're using right now for this conference. That's becoming more virtual and more capable. Last but not least, education, making sure the education used to be pretty much for the techno geeks. Business people like me would struggle. Now there's a recognition that it's not just the developers, but the business leads have to be involved and understand this technology to build the vision of how those pieces can be reused. And last but not least, just like Gravity has brought in community-based organizations, there's a variety of new communities that can come into the training and to get engaged. So I say all that to say HL7 is evolving, much like FHIR as a new web-based technology is available to make sure that we on this call, on this conference, can participate more effectively regardless of where you're coming from. The opportunity to use this internet technology is really amazing, and it's going to be exciting what we'll see happen in the next couple of years.
And Nolan, before we wrap up, I'd like to tag on to what Lenel is saying there as somebody that's been involved with HL7, not as long as Lenel has, but for probably half a dozen years or so, maybe more, is I think one of the things that's really amazing, and I would say, Lenel, I don't know if you agree, is sort of the unexpected sort of benefit and sort of power, not just of the standards building that we're doing, right? The ability to build implementation guides faster and to be able to convene folks around sort of these big domain problems in projects like FAST has been great. But I think this community aspect that Lenel was sort of talking about there at the end, and the ability to pull people in that aren't the coders or the architects, but really the people that understand the business problems that need to be solved, I think is a big part of how we're transforming how we solve problems as an industry. And this ability to be able to decide that we're going to figure out the rails together, and people are going to differentiate on better service, better content, better user experience, better service to their members or their patients or their partners. I think is such a sea change in the time, the dozen or so years that I've been in healthcare. I think that we're at a inflection point in an industry that doesn't happen very frequently, I think, in folks' careers. And you can hear sort of the enthusiasm of the speakers earlier today, really the power of getting the consumer at the table and the power of, sort of all of these existing technologies and organizations sort of pivoting and getting more agile to be able to support them.
Agreed. Hear, hear. Nolan.
All right. Well, thank you. We have had a couple of questions come in, so I think we can pivot over there. And you can keep these slides up for now because you might want to go back and reference them. Lenel, I think you shared this, but maybe if you could recap, how does one get involved in FAST?
Do you want me to take this one?
Yeah, I'll Jocelyn.
Okay.
My team does PM support. So there's a couple ways that you can get involved in FAST. And I think the easiest, most direct way to get involved in the project is actually just to go to your LinkedIn account and join the FHIR-At-Scale Taskforce. There's actually a LinkedIn group. If somebody goes to me, you'll be able to see that I'm a member of the group. In addition, there's a Confluence website. There'll be links here. I'll get the slides to you guys so that you can post them and share them. But there's a way to be able to access a Confluence, an ONC Confluence-based page where there's access to all of these resources. And today there's a technical learning community that essentially allows you to be downstream of any events or conversations that are going on And I would say candidly, and Lenel, I don't know if this is a fair statement to make, I think as we're moving from the idea of identifying what the barriers and challenges are, the best place to get engaged right now around the actual work of the different Tiger teams is actually to find out what the artifacts are that are being built and come engage in the HL7 process, whether that be coming to the work group meeting that's supporting that implementation guide, coming to a connect-a-thon, or just pulling down the draft guides or the project scope statements and giving feedback as part of the HL7 process. The work is pivoted from sort of the conceptual to the actual around a number of the emerging areas. So that's probably the best, meatiest place to plug in right now.
Yeah, let me just quickly add that in addition to pulling down the artifacts that describe what each of the teams have done in their vision in the diagrams, there are, I believe, at least 3 projects that have been started at HL7, so you can get familiar with the proposed approach, but then you can work in the appropriate work groups of HL7. If you're involved in directories, for example, there's a work group that's assigned for that. So for each project scope statement, it will tell you which work group of HL7 is doing the work, and you can engage in the actual work, or again, participate in the pilots or connect-a-thons using some of that work. They may not be there now, but they're going to be there soon. So connect-a-thons, participation in work groups, and then participation in pilots are definitely what can happen in Q4 and all of next year. There's going to be a lot of activity here for people to get engaged in with ONC fast. Nolan?
Yeah, I think that's just to add one more point on the pilot side, there are participants. The FAST group is actually using a number of the emerging implementation guides, the functional use cases like DaVinci use cases, to test out some of these emerging guides that are being built. So, if you get involved and you get looped in, you'll be able to find out who's actively participating and looking for partners to help with their pilot activities.
Terrific. Yeah, I feel like the two of you have the crystal ball that the industry is trying to look into. And I think you both have used the word reuse and repurpose on a couple of occasions today as it relates to the FHIR infrastructure and what's to come. I'm not certain every organization has made decisions with that lens and are probably always making new decisions, and so maybe if you could double back just on the question here that I'm trying to frame is double back around how you think organizations should be reusing and repurposing the work that they've done, whether it's for additional regulations or the use cases that you've helped spell out here.
Let me take a first crack at that, Jocelyn, which is because I can tie it from value-based care in DaVinci to Gravity. So if I'm doing value-based care to improve care coordination between a payer and a provider, the care managers at a payer and the care providers at a large institution, when I turn around and go to Gravity and I'm trying to extend out to the community health worker at an FQHC or is working at a community-based organization or social services agency from a city or a state, they need the same thing. I need to know who you are, where you are, what's the latest status of your health condition. Now I want to layer on top of that, are you having problems with behavioral health? Are you having issues of homelessness? Because it's really hard to give someone a medication that needs to go in a refrigerator if they're living out of their car. And that's not something we usually ask in healthcare, but now everybody has woke up because of COVID and go, oh my God, if I don't know where they live and if they have a refrigerator or have access to food because they're in a food desert, I need to prescribe the care and resources in a new way. And those resources now can tie to the same infrastructure. Where's the hospital? Where's the specialist? Where's the food bank? Where's the transportation? All of that can run on that same backbone if everybody understands how to take it and add the missing data elements, or take it and add the different operations and the different users to be able to run off that same data. Jocelyn?
I think that that's just such a great illustration. And I think that I'll be more blunt, I think, than Lenel is. That's my role, is this idea that, you know, you need to look at your investment in FHIR strategically. And we get that there's people out there that need to meet a deadline or meet a regulatory requirement. And so you might do something tactical sort of to meet that. But this idea of making data exposable, right, and making it so that you've got, you know, more real-time interactions with your partners allows you to add more partners, like you're hearing Lenel describe, right? It allows us to master data and understand our data in a way that we don't today. And it allows for a seamlessness for, you know, a care team or, you know, people that are in, you know, more strategic partnerships to really focus on the patient and what's important for the patient. And I think that this reusability component isn't something controversial, but I think when we look about what happens inside of large complex organizations on a day-to-day basis, you know, often the tactical decision gets made. And so I think my challenge, and I think our whole community's challenge to the folks that are sort of out here, is to really to get people to stop and think and take that step back to figure out what is my long-term strategy with how I'm going to make my organization interact with its ecosystem by empowering APIs. And FHIR just happens to be the way that we're doing that in healthcare. And we're seeing, right, everywhere else in the world that we work, all of this unexpected, unanticipated benefit of freeing information to be used in new and novel ways, securely with consent, that are going to allow us to tackle problems that we didn't think were possible, like that Lenel is just scratching the surface on.
Perfect.
The water's warm.
Yeah, no, we should go back and capture your combined answers to that question, because I think it really sums up a lot of what we've heard today and a lot of what the opportunity is in the future. So thank you both for carving some time out. By the way, that your answer was the perfect transition to our next segment, which is around payer and provider collaboration with FHIR in place. So you know, no better way to tee that up than your presentations and your answers to those questions. So thank you guys very much. Appreciate it.
Thanks for being here. Thanks for having us.
All right. Take care. Let's see.